Well, good morning, everyone, and welcome to our cardiology grand rounds. It's a pleasure to be here with you and all of you who are joining us live through various feeds. You know, I keep learning about them every day, live stream, Facebook, YouTube. And I'm happy to announce that we have about 15,000 plus followers on YouTube. So we love to share knowledge, whatever we can share with you in different forums. Actually, there's a new forum that we introduced last week, which is a live webcast afterwards, an interview and answering questions that you may have. And we will do that with our cardiology grand down speakers. And I'll have some instructions for you. If you want to send a question, you can send it to the number 37607 and put in the discussion or the title DICET, D-I-C-E-T. So, and I think these instructions will be available also online. So if there are some important questions, hopefully we'll be able to answer them. A few other things that I'd like to announce is the upcoming two conferences, 5th Annual Adult Congenital Heart Disease Symposium, October 12, and the Pumps and Pipes, probably this is the 12th year, November 11. Let's talk about Grand Rounds today. This is a very special Grand Rounds on a topic that is very dear to most of us and dear to the population, which addresses risk. And who else is best to talk about this is our guest speaker, Dr. Neil Stone from Chicago and Northwestern University. It was a pleasure to get together yesterday with him, and he holds the Robert Bono Professorship of Medicine and Preventive Cardiology, an individual who is a giant in cardiology, and I think it is heartwarming to see that, Neil, that you hold this chair in Robert Bono's name. Dr. Stone is certainly world-renowned in the field of lipids and risk. Actually, he started that very early in his career. I would say when he joined for 3 years or so the NIH. And he tells me also that he was in the group with Dr. Gatto, who we know very well, and really the pioneers of the people who started the lipid revolution, I would say. And at early stage, we didn't have too much to offer our individuals who had very high lipids and understanding about risk and what to do about that, from the early days of cholestyramine to all the newer modalities nowadays. It really has been an amazing journey. You know, Dr. Stone has been involved with this since in the early 1970s, and not to date him because he started very early in his career. And actually, you know, when he came back to Northwestern, he instituted a lipid clinic back in 1974, and actually that's what he does most of his time nowadays, is taking care of patients, in addition to doing research. And certainly the way we know about him the most is a leader chairing the guidelines of lipids by the ACC, the American Heart Association, 2013, when I just finished my presidency. And it was a milestone and a change from the early days of targeting goal to thinking about risk. And I think there was an early uproar regarding that, because people had to reset the way they think about it and how the clinical trials were conducted. And he's a vice chair of the recent guidelines, 2018, that were presented at the American Heart Association. He has won numerous teaching awards, 2002 New Jersey Healthcare Foundation Humanism in Medicine Award, in 2014 Physician of the Year Award by the American Heart Association, 2018 the Joseph Stokes Award from the American Society of Preventive Cardiology. He's certainly a leader in the field, and we can't wait for him to address the lipid guidelines, a perspective, particularly from a risk of primary and secondary prevention. Neil, what a pleasure having you. Thanks very much.
Well, thank you, Bill, for that very kind introduction. It's been just a real pleasure to visit here with you and with the whole team here in Houston. I'm talking about the 2018 cholesterol guidelines. Now, the problem with guidelines is that I think best summarized by this quote. When I was a young cardiologist, I had just come on staff at Northwestern, and I recommended a patient for a very complicated surgery, and I really thought, given my young age, he would ask for another opinion. And I said, would you like a second opinion? He said, no, doc. He says, I'm going with you. I said, thank you. I said, why? And then he said, well, a person with one watch thinks they know what time it is, but a person with two is never sure. So it turned out okay, and as the chair, as a member, and then a chair, and then a vice chair of several different guidelines, actually 4 different guidelines, I thought what I would try to do today, and this is what I've been doing in my lectures since our guidelines came out, is try to show you not how they're different, but how they're actually all the same, and how a clinician can take a look at a patient and bring the best of what the guidelines show to their interaction with the patient. So number 1, all individuals, these are the ABCDs, the A, over the life course, heart-healthy lifestyle. It sounds sort of a given, but actually we found out that very often lifestyle is not encouraged among families in the pediatric and adolescent age ranges, that in young adults 20 to 40, they're in a hurry, and we don't often have good suggestions. But most important, when you begin to treat people with statins, they have to adhere to a good lifestyle too. We actually have data to show that if your lifestyle is poor, you diminish the benefit of the statin. So you don't prescribe a statin, and I'll make this point over and over again, you prescribe statin and lifestyle. And if you'd like in the questions, I can sort of share with you what I tell patients in a 1-minute session on lifestyle. 2, assess risk. Those at highest risk deserve the most intensive prevention. That's been a watchword since the 1990s in terms of preventive cardiology. But sometimes it gets lost when we hear numbers floating around. Everybody's got to be under this number or that number, and we forget it actually depends. Years ago in a New England Journal editorial, Dr. Don Lloyd-Jones and I said, lower is better, but it depends on in whom and how you get there, essentially. Number 3, be a clinician. Personalize risk, look at the patient. I've seen cases where patients were prescribed medicines where nobody looked at the patient. I saw a man who was 78 and who was given a high-intensity statin because he had some mild chronic coronary disease. It made perfect sense, except he walked in on 2 crutches, and he said to me, he says, I'm afraid of taking a statin. If I get any weaker, I'm in a wheelchair. I said, you're right. We're going to figure out a way not to use a statin because that's the one side effect you can't handle. He's in his 90s now, and we're doing great, and we avoided the statin. Doesn't mean statins aren't the drug of choice, but in this person, they would have been a very poor choice. Number C, cholesterol-lowering therapy based on evidence from RCTs. Why do we start with a randomized controlled trial? In 2013, we based our guidelines almost exclusively on RCTs, and a lot of people said, well, why not use all this other information? Well, we said you've got to start with the RCT because there's 2 things about an RCT that are valuable. 1, it has the least bias because neither the clinician nor the patient knows which treatment they've been assigned. But number 2, and this is what's often forgotten, that it's in a specific patient group. What makes the statins such a powerful choice when it comes to treating cholesterol? Well, we have all these RCTs in all these different patient groups, whether it be general populations, secondary prevention, diabetes, chronic kidney disease. Statins have been used in a wide variety of populations, and they all seem to come out the same. They provide benefit at a very acceptable, with a very acceptable safety record. So RCTs is where you must begin and should be the basis of therapy. The literature is strewn with cases where People just went with intermediate endpoints, and they later learned that the RCT showed the benefit was no good. The classic example is torcetrapib, a cholesterol ester transfer protein inhibitor. It raised HDL, it lowered LDL, it couldn't miss until they did the randomized trial and showed there was an increased mortality from it. So we don't use that drug. Lastly, decision shared. One of the big advances in 2013 that have now continued in all the guidelines is that we need to elicit patient preferences. Beliefs have to be respected. There has to be a conversation between the clinician and patient. I contend it takes very little time, and the key is how you frame the discussion. So we came up with the top 10 messages for our guidelines, and I'm trying to give you pearls from each of these top 10 messages that you can take back to your practice. One, in all individuals emphasize a heart-healthy lifestyle across the life course, as I've just said. Preventing risk factors early is powerful. When I see people in their 20s and 30s, I look them in the eye and say, you know, if you can have optimal risk factors till age 50, the likelihood you'll ever have a heart attack or stroke is minimal by age 83, minimal. And what you extend is not your life, but disability-free years. It's a powerful construct. And remember, we don't prescribe statins, as I tell people. I'm giving you statins and a healthy lifestyle. In fact, I once said, which arm do you want to cut off? The arm that gives you the lifestyle, the arm that gives you the statin? I need both of them. And we have data to show that behavioral counseling for intensive diet and physical activity, we've got support staff that can help counsel patients and help them reach these important goals. This is a slide that talks about the fact that not everybody can get lifestyle because if you look at the blue line, which is secondary prevention, and you see the slope where you look at outcomes as a function of LDL, or the red line, primary prevention, less steep slope because these are a healthier group, you see that as we get lower and lower, it's in millimoles, and remember, the molecular weight of cholesterol is 387, so 38.7 milligram per deciliter is a millimole. Just remember 40. So 2 millimoles 80, 4 millimoles 160, 5 millimoles 200 essentially, and you can see that all the clinical trial data shows that as we keep treating lower and lower cholesterol, the lower we go, we still get benefit. That's a powerful point, but it really benefits those at greatest risk. So number 2, in patients with clinical atherosclerotic cardiovascular disease, reduced low-density lipoprotein, LDL cholesterol, with high-intensity statin therapy or maximally tolerated statin therapy. You all know this. The more LDLs reduced on statin therapy, the greater the risk reduction. But it depends on 2 things. It depends on adherence, and it depends on whether or not they're going to be responsive. You know, in the Jupiter trial that was primary prevention, the average response to rosuvastatin was 50%, and that was a positive trial in a very short time. If you actually look at the percent LDL lowering, the benefit seen was an absolute function of the percent LDL lowering when they looked at that data. So we want to tell people you must take your statins with high adherence, and we want to try to get that full 50% lowering. I don't know how many of you ask about adherence at every visit? Do you take your pills? How many ask the specific question, how many of you missed in the last 30 days? We did a study where I sent a freshman medical student to cardiology offices all over Chicago, 3 academic and 3 top private practice cardiology groups. And she got to interview the patients after they saw the cardiologist. Then she interviewed the cardiologist, and she asked the cardiologist to rate each patient on their adherence. 2/3 of these great cardiologists, and these were terrific people, didn't know their patients had poor adherence because they failed to ask the key question, how many of you missed in the last 30 days? Try it, especially the house staff. It is stunning when people say, you know, I missed 2 weeks because I went on vacation. And all of a sudden, instead of giving them an extra non-statin, you say, well, let's get another blood test on a statin. Number 3, we talk about thresholds, not targets. We said if you have a threshold of 70 1.8 millimoles per liter, consider adding non-statins to statin therapy. Now, how many here like targets? Just raise your hand. It's perfectly fine to like targets. How many like thresholds? So I'm going to raise my hand, and I'm going to try to convince you, if I can today, that it's a much better way to think about it. So the clinical studies, the PCSK9 studies, enrolled people with 70 milligrams per deciliter of LDL or more. And remember, the ezetimibe study, they started with around 69, 70 milligrams before they added ezetimibe or placebo to the moderate intensity statin and improve it. And so 70 is a natural number to be a threshold to consider, does our patient need ezetimibe, a PCSK9, or ezetimibe and a PCSK9? But these studies looked at people at the highest possible risk. If you only remember numbers and say, I'm going to get everybody to this number, you forget that as your risk goes lower, the absolute benefit you're going to get is going to be less. So we want to try to match the intensity of our therapy to the absolute risk reduction. If you have a lower risk person who is just short of a target and you add more therapy, you're actually getting very little benefit and you're increasing the expense of the therapy and the chance for side effects. If you have a high risk person, very high risk, and they just get to the goal, they get to, say, 65, well, maybe that's really not enough for them. If they're very high risk, maybe they need very intensive therapy. So a threshold puts the doctor, puts the clinician back into the risk discussion and allows you to channel the best treatment for everybody. One size does not fit all when it comes to treatment. And our guidelines said that to decide who was very high risk, we said, first of all, do you have two of major ASCVD events? They could be a recent acute coronary syndrome, history of MI, history of ischemic stroke, symptomatic peripheral vascular disease. So two of those makes you very high risk. You really have a 30%, 40, sometimes 50% risk of an event in the next 10 years. Or one of those with high-risk conditions like age 65, hypercholesterolemia due to genetic or heterozygous FH, diabetes, hypertension, smoking, CKD, persistently elevated LDL despite therapies, over 100, because that group gets a very high benefit. We saw that in Odyssey outcomes. History of congestive failure due to ischemic cause, of course. And so all of these factors can be considered. This is a simple dot phrase on the Epic computer. And so rather than just say clinical ASCVD, go to healthy lifestyle, and then simply either go to not very high risk or to very high risk, let's focus on the very high risk. The not very high risk gets the high intensity statin. We're aiming for a greater than 50% reduction, and we've got a 2B recommendation. If you can't get 50%, you might even add ezetimibe in this group to get there. Age 75, if you've had an ACS, you get benefit from a high intensity statin. Actually, in the Improve It trial, by the way, over age 675 was a group that got a special benefit by getting further LDL lowering, and continuation of high intensity is reasonable. But remember, when you use high intensity therapy in those over 75, you've got to look to be sure it's safe. There's a lot of conditions you've got to check. Well, what about the very high risk? Here's where the Improve It data was interesting. Dr. Bahula and colleagues at the Brigham looked at all of these markers that I told you about that are part of how we determine who's very high risk. And they found out that if you were assigned to simvastatin and ezetimibe or simvastatin and placebo, and you had very few of those high-risk markers, your risk was about the same at 7 years. Where if you had 3 or more, there was a very big difference in terms of those who had their LDL lowered versus those who did not. See a 7%, 6% reduction here. So 2 or more gives you a benefit, but 3 or more definitely. So you care about how high risk your person is, how many of these other major factors are present. Let's give the most intensive therapy to the people who deserve it. And So we wondered when our categorization of very high risk came out, how would it look when we look backwards at randomized trials? And we have our answer. In the Odyssey Outcomes trial, 2/3 of people enrolled in Odyssey Outcomes. Remember, they got maximally tolerated statin and then either a PCSK9 or placebo, and in this case, alirocumab. And those who were at very high risk had more than double the risk of recurrent events and had a greater absolute risk reduction with the intervention. So knowing somebody's very high risk means you're identifying people who are going to have twice as many events as the ones who just have coronary disease. That one vessel CAD on an angiogram, they may get an angioplasty, but they're really not in the very high risk group. And so we said for those who present with ACS or present with multiple factors plus MI or stroke or peripheral vascular disease, and remember the polyvascular patient with atherosclerosis is really high risk. Our strategy was that adding ezetimibe is 2A based on the IMPROVE-IT trial. You could certainly consider PCSK9, but we said because of cost, availability, and the fact that some people get a very good response to ezetimibe, you could start with ezetimibe first, and if you don't see a full response, add a PCSK9. Or some people, particularly if the LDL was greater than 100 despite aggressive care, could go right to the PCSK9. So number 4, in people with primary hypercholesterolemia, you don't need to calculate risk. You see a person who has a primary elevation of over 200, you give them a maximal statin therapy, and then you do have non-statin options to get LDL even further, particularly if they have multiple risk factors, because you'd like to get the LDL the threshold is 100. Is this person deserving of getting the LDL even lower? I saw a lady in the office, though, the other day, it was 2 years ago, her LDL was 230, and on repeat it was 220. And I asked my fellow, what would you like to give her? He said, 80 of atorvastatin, Dr. Stone. I said, let's take a nutritional history. She was on this crazy diet, coconut oil, hardly any carbohydrates, just lots of fat, high-fat dairy, fatty cuts of red meat. I said, why don't we just see for 3 months, since there's no family history of high cholesterol, no family history of premature heart disease, let's see what happens when we put you on a Mediterranean-style diet, where we talk about good fats like extra virgin olive oil, canola oil, try to avoid the bad fats and try to avoid the bad carbs like sugar, but have plenty of fruits and vegetables and whole grains. Her LDL fell to 140. But I said, why don't we come back in 6 months? It fell to 130. Why don't you come back in a year? It fell to 120. And I turned to the fellow and I said, how much atorvastatin do you want to give her? He said, I think we'll pass on this one, Dr. Stone. I said, good call. And so we're talking about severe primary hypercholesterolemia. So again, my message is the best thing about the guidelines is it puts the clinician into the guidelines. These are not rigid numbers. What about diabetes? Well, if you have diabetes and you're 40 to 75, we've got excellent RCT data to say you should start a moderate intensity statin. You get benefit. You don't need to calculate their risk. But what if they're at higher risk? This is the pearl. Look to see which of those with diabetes actually benefit. Do they have multiple risk factors? Are they over age 50? Do they have long duration of type 2, more than 10 years, more than 20 years of type 1? Albuminuria, CKD, retinopathy, neuropathy, peripheral vascular disease, a great patient to do an ABI in to document peripheral vascular disease because often they're asymptomatic. And these patients perhaps deserve even more aggressive care with a high-intensity statin. Or if you can't achieve the 50%, then consider adding ezetimibe to your statin. In adults 40 to 75 evaluated for primary ASCVD prevention, have a clinician-patient risk discussion. I think I'm most proud of emphasizing that in the 2013 guidelines, that the 7.5% was a threshold for determining people who have been shown by RCTs to benefit. Some people have published data to say they'd wait till 10% or 12%. That's still consistent with what we said because it was a threshold, but it depends. The key is that when you look at a patient and say, you know, I don't treat cholesterol, I treat risk, and your risk is high enough to consider whether a statin would make sense for you to lower your risk. Some people say, you know, I've heard on the internet that statins are bad. I said, well, the problem is when they do double-blind trials and people don't know which drug they're taking, it's hard to show that. It's hard to show all the stuff that's written on the internet. And are you aware of the fact that when they've given people who claim they had statin side effects a placebo versus the statin, but didn't tell them which they got, 40%, 30 to 40% of people got symptoms on their placebo. They were actually able to take the statin. And so we need to think about benefit versus risk. And so the group to do that in is the adult 40 to 75. They don't have diabetes. They don't have that really high LDL, but is primary severe hypercholesterolemia. But they do have that 10-year risk that's greater than 7.5%. We now have 4 clinical trials that showed, 3 clinical trials that showed with risk below that they benefited, and then a 4th one, HOPE-3, the average risk was 8.7% in terms of fatal, non-fatal endpoints of ASCVD. And so a moderate intensity statin is supported by the RCTs, but first there should be a discussion of treatment options. And to do that, we recommend 3 tools. Calculate their risk, C. P, personalize the risk decision. And then lastly, reclassify risk. Risk-enhancing factors, as I'll point out in a second, favor statin therapy. We need to say to patients who may not understand what a number like 7.5 or 9.3 or 12.2 means, we need to say, here's why this makes sense for you. And if uncertain status, consider using coronary artery calcium. Thanks to the MESA trial, I see Dr. Nasser in the front row, and thanks to his great paper to show that coronary artery calcium studies reclassify risk. They improve specificity, and they may be just what we need. So let's talk about risk-enhancing factors. They make the most sense, not in people with low risk, less than 5%. Almost always you can work with lifestyle. Or very high risk, more than 20%. These people benefit from a statin. Even if their calcium score would be 0, it still leaves them at a high risk. But for that intermediate range, that 5 to 19.9%, this is where these risk-enhancing factors make sense. And remember this pearl, even under age 40, in the 20 to 40 range, there's some FH patients who were missing. Oftentimes, they're young adults with LDL 160 to 189. They've got a family history of premature ASCVD. 10 to 20% of one large sample of young, healthy women actually had some strong risk factors, and they needed to be teased out. And the guidelines don't call them out directly, but we call out the fact that you've got to look for them. So what are they? Family history of premature ASCVD. I think every good doctor takes a good family history. But remember, there's a big difference between my family history, where everybody on my dad's side has a heart attack before age 50. Most of them don't make it, versus the person who has no heart disease in the family, and the dad at age 56, being a heavy smoker, had sudden death, but his brothers and sisters don't have problems. There's just nobody else in the family. There are different gradations of a family history we need to learn to think about. Persistently elevated LDL, 160 or more, that was present from the prior guidelines as an important enhancing factor. Metabolic syndrome, chronic kidney disease. The data shows that if you have the people with chronic kidney disease, 92% over age 50 have a greater than 7.5% risk. So they were picked up by the prior guidelines, but now we're calling them out directly. History of preeclampsia or premature menopause. These are guidelines that are trying to emulate what the women's guidelines did almost 10 years ago, where they said you've got to look at special factors for women, such as preeclampsia or premature menopause. Also ask about gestational diabetes. Chronic inflammatory disorders, rheumatoid arthritis, psoriasis, chronic HIV. In the text, we talk about lupus as well, but those are the big chronic inflammatory disorders that also put a person at special risk. High ethnic groups, patient is South Asian, they give you a positive family history. Their LDL's not as high as you might have thought, but that's a very high-risk patient. They often have, as we'll see, a high LPA. Persistent elevations of triglyceride, fasting or non-fasting, greater than 175. We have data to show that a non-fasting triglyceride, if it's persistent above 175, may be very helpful. Now, the problem with Northwestern is we're ringed by 4 donut shops. I don't know if it was done purposely to improve business, although we seem to be busier than we need to be. But if the patient has just had 2 of their favorite donuts, I would not draw blood. I would try to get them to have a lighter breakfast. But if you see patients in the afternoon, getting a lipid panel in the afternoon as screening is perfectly fine. And actually, the non-fasting triglyceride may give you a sense of how many remnants they have and what's going on. So, on genetic disorders, it can help you diagnose type 3 with a cholesterol, triglyceride, and ApoB. Dr. Alan Snyderman's championed that, and it's very helpful. It can give you an idea of which hypertriglyceridemia groups have excess of atherogenic particles. Some people have high triglyceride, but their ApoB is not that elevated. Others do. So an ApoB may be worth looking at it in this context is a risk-enhancing factor. High sensitivity CRP, 2 or more, anchiobrachial index may be helpful in selected older patients, and elevated LPA. The data shows that if you measure milligram per deciliter, which is measured by most of the people that come to see me, more than 50, a lot of studies show more than 50 is where you begin to see an increase in risk. There's a important move now to have people measured nanomoles per liter, have it measured that way. 100 is the 80th percentile, 125 is the 85th percentile. They're very close. And the point is, elevated LPA may be especially helpful in those with a family history of premature ASCVD. The Europeans have asked everybody to get 1 LPA once in their life. I think we need to sit and think about what the benefit risk of that would be. Certainly, if someone has a very high LP(a), that's worth thinking about. Risk-enhancing factors, we pointed out that LPA, if it's just barely above the upper limit of normal, may not be a powerful risk-enhancing factor, but certainly at higher levels of LDL, it's very important in those with FH, or higher levels of LPA, it may be. Number 9, in adults 40 to 75 years of age without diabetes, with LDL greater than 70 and at a 10-year risk in that intermediate range, what about measuring coronary artery calcium? Well, we've got 2 important trials. I heard one critic of coronary calcium say, there's no RCT showing that we should do a coronary artery calcium test. That person was right if you're advocating that everyone gets a coronary artery calcium. That would be a trial that would be helpful. But we're not advocating that. We're asking for selective use of coronary calcium. We're saying it's a risk decision tool. And there we have 2 very important data. The MESA data, a really well-categorized study with 4 important groups that are ethnically diverse. And then the bioimage study that looked at men 55 to 80, women 60 to 80. And both of these trials showed that coronary artery calcium, or CAC scores, can help reclassify 10-year ASCVD risk, especially in the intermediate risk patient. A CAC score of 0 reclassifies them down, so perhaps you could defer statin therapy with a few exceptions, or a CAC score may indicate much higher, that they really have to take this risk reduction even more seriously than you may have suggested. And the pearl is, we said that people have had calcium scores of 0 who are heavy cigarette smokers, and they can present with an acute MI because they've ruptured a non-calcified plaque. So we tell people if you have a CAC score of 0, you've still got to get off the cigarettes. It's not a shield of immunity. Diabetes, you may have a low 5-year risk if you have a CAC of 0, but your diabetes doesn't go away. The diabetes is is the gift that keeps on giving adverse consequences as you get older, unfortunately. And so we don't recommend it there. We think those with diabetes need aggressive prevention therapy. And remember the key thing about a patient with diabetes. Who would you like not to see in your ER with an acute MI? A diabetic or a non-diabetic? If you had to choose, you'd prefer to see the non-diabetic, because the patient with diabetes has twice the mortality, twice the risk of failure. They don't do well with angioplasty. You know, they're headed for a bypass with that risk. So if you can prevent the first MI in a patient with diabetes, that's a big deal. And that's why you want to make sure that you favor them with preventive therapy. And also those with a very strong family history of premature ASCVD, I think we've got to take that history seriously. 1 to 99 is always that gray zone, but the studies have shown if you've got calcium, you've got atherosclerosis. It's not a risk, it's determinative. It's just a lower risk, and they're going to need to be followed and perhaps treated. If the calcium score, though, is greater than 100 Agatston units or greater than the 75th percentile, which you can get from the MACC calculator, just Google MACC calculator, it's pretty easy to find. Statin therapy is indicated unless otherwise deferred by the outcome of the risk discussion. And lastly, assess adherence and percent response to LDL lowering with repeat lipid measurements 4 to 12 weeks after statin initiation or dose adjustment, and then repeat as often as you need. I've seen people who are getting lipids every 6 weeks, and they're perfectly stable. They don't need it. Maybe once a year is all they need. Others have huge adherence problems. They need to be watched more closely. So 2013, we said measure LDL and adjust based on their adherence and the adequacy of their response. And we said it again in 2018. Remember, it's not what you expect, it's what you inspect. And remember that decreased adherence to statins is not only important to know, but in a VA study, those who had poor adherence to high-intensity statins had a higher mortality rate. It's life-saving to take your pill if you deserve it. So let's go back to what I've said, the ABCs. Let every patient know that the heart-healthy lifestyle is just as important as giving the drug therapy. I tell every patient when they leave the office this one line. I've done it for years. Remember, eat less, eat smart, move more daily, and don't gain weight. And I write it down. Eat less, eat smart, move more daily, and don't gain weight. People have seen me 3 years later. They still remember that. That's the soundbite. They've forgotten the pictures of the grandchildren in the office, but they remember the soundbite. Assess risk. If highest risk, more intensive prevention. Be a clinician. Those risk-enhancing factors, the judicious use of coronary calcium, that's called being a clinician. Cholesterol-lowering therapy based on evidence from RCTs. That's where we begin. That's why guidelines are so valuable. Although guidelines start with it, there are differences in guidelines. For example, the Europeans have hard fixed numbers, 55 and even a 2B recommendation of 40 that differs than our threshold concept. We feel strongly about threshold, but you're going to have to decide what does the RCT evidence really say. And lastly, never be afraid to share the decision. Tell me what you think. How do you feel about this? Some people are very risk averse. Other people are pill adverse. Some people really don't want to take a pill. And you have to really ask them what would it take before you would actually start taking therapy. And then when they tell you, you can actually design a therapy. If someone says, you know, unless I knew I was going to die, I would never take a pill. Well, you can talk for about 30 days. You're not going to make any difference. But you could refer them to come back to have a nurse visit who could review what the information is about how preventing a heart attack or stroke can make a difference in their life. You don't have to make a decision that day. So I'd like to stop there and see if there's any questions. Thanks so much.
Thank you very much, Neil, for a nice, concise, and actually very informative recommendations from the guidelines. Questions?
Yeah. Yes, please.
Thank you. That was a really, really wonderful presentation. So you touched a little bit on LPA and certain high-risk groups. If you do check it and you do find an abnormality, how are you currently treating it, or what are you doing for it?
Okay, so there's a big difference in life between risk markers and risk targets. Back in 2006, I was almost thrown out of a grand rounds when I came up with the slide that says HDL is a risk marker. We haven't proven it's a risk target. Everybody said, Dr. Stone, what are you telling us? Of course HDL, it's the good cholesterol. You want to give drugs to raise it. We've got niacin, we've got fibrates. I said, we don't have data. It's a risk marker. It's a great risk marker. Well, guess what happened? A funny thing happened on the way to that conclusion. 2 or 3 years ago, one of the speakers at one of the grand rounds says, let's face it, HDL cholesterol is not a risk target. Changing it doesn't make a difference. Well, right now, what we know is LPA is a great risk marker. But the trial to prove whether you treat LPA, it makes a difference. We don't have that data. And I think you've got to stick close to the data. So we're hoping that we're going to hear about positive results from an ongoing clinical trial that'll tell us whether treating and in whom we treat makes a difference. But until then, it's a risk marker. It just says if you have an elevated LPA, you become, if you watch a lot of detective shows, a person of interest. It doesn't mean you're arrested. It doesn't mean you're sent to the slammer for 20 years, you know? It just says you're a person of interest. And so, therefore, now we take a more detailed family history and we try to get an idea of how high the LPA is. If it's very high, that's really very important. If it's in the context of very high cholesterol. For example, the Women's Health Study, which is this large study, showed that for women who had elevated LPA, they didn't begin, and they measured it in milligram per deciliter, normal range 0 to 30, they didn't see benefit till above 50. And even then, it didn't change, it didn't move the needle a lot if the cholesterol was under 220. So in women who get an LPA measured and it's just barely elevated and their total cholesterol is low, it's not going to change how we treat them. Whereas if I see a patient with FH and has got a high LPA as well, and it goes along with that family history, well, that's a person that I'm obviously going to be involved with more aggressive therapy, which our guidelines are consistent with. But right now, it's not a risk target, and I think everybody should know that.
Henry?
So, oh,
There's been recent interest in patients with very high HDL.
Yeah,
And that these patients present with no other risk factors, and yet, do you know how to treat them? Do you have any ideas about underlying causes?
So I'll take the Fifth Amendment and say that although I've treated them for literally 49 years, I started at NIH in 1970, I'm still not sure what I'm doing. Because let me tell you the data that I know. I know that in terms of what we call genetics, some people with very high HDL have genetics that perhaps are not ideal. They have certain risks. But some people have very high HDL probably due to a combination of genetics and acquired factors, such as hormone therapy if they're a woman, or heavy alcohol, which almost always tends to be the guys. In fact, in the Moscow Lipid Clinic, there was a paper in the 80s that really shook everybody because HDL wasn't a risk factor for heart disease. And the reason being is they had very high HDLs that were about 80 proof when you looked at it, because it was a high vodka consuming population probably. And so it might be a clue to heavy alcoholic intake, and that's not a good thing to do. John Wilkins at Northwestern took a look at several different populations, and they showed that the HDL for women above 85 didn't really protect her anymore. That was not protective. And we really couldn't make a definite statement about what to do with it. But I do know this. If they have a really high HDL, I have to say to them, most of the things that I know about don't apply to you, including using HDL in the Friedewald formula. I'm subtracting 120 from the total cholesterol minus, the triglyceride divided by 5. I don't know what that means. That's you got this grossly cholesterol-laden HDL. So I measure ApoB in those individuals because that's independent of the cholesterol and gives me a better idea of their atherogenic risk. So what I would do is I would measure ApoB. I would tell them that we need to follow you. I followed many, many people for a long time, and I haven't had to depart from what I normally do in them. So I don't know about a specific risk which requires a specific medicine. But I certainly don't give them a pill to lower their HDL. But it makes you worry about sometimes the pros and cons of postmenopausal hormone replacement therapy, which maybe is going on too long. Maybe that can be changed. And heavy alcohol is always worth finding out about. Yeah.
Again, thank you very much for a great presentation. I think I have 20 questions, so I'll ask two. One of them is actually, if you can, be a little bit more specific on the LPA conversation. In terms of, we are seeing more and more people in their 40s and 50s where their usual cholesterol guideline recommendations are met on statins. How are you managing those patients who still continue to have elevated LPA? Do you set them a number? Because I keep on getting those questions from our patients.
Again, it's a risk marker.
Yeah.
It would say that this person deserves heart-healthy lifestyle, statin, as per the guidelines, but you don't keep measuring the LPA. I hope you don't keep measuring it. There are two things that get worse on statins that really bother people. The LPA level may get worse on a statin. I don't know what that means. Calcium scores get worse on a statin. I sure am not going to chase those down because the studies have shown that the plaque's getting better even if the calcium's continuing. So LPA is a good marker. It's so highly inherited. 95% of the time you get one LPA and you know where that person stands, you've got your marker. And that just tells you whether the height of it tells you whether they're a person of interest. But we don't have data to show that you're going to be adding, some people used to add niacin to try to lower it, but we've got data to show that the safety aspects of niacin are clearly not worth that. So right now, I think it's a marker.
Okay. So just to make sure I understand that, if they met their LDL, HDL numbers and try, the panel numbers, there's no reason to increase the dose of their statins?
So first of all, I don't know what you mean by they met their numbers, because I remember we're the guideline that talks about a threshold. So if your primary prevention and you get a moderate, and you're on a moderate intensity statin, the question would be, are there any factors that would make you want to treat with a high intensity? Is there anything that would increase their risk? Well, a really high LPA could greatly increase their risk. I saw a person with a LPA 7 to 8 times the upper limit of normal. He was on a moderate intensity statin. We discussed a more aggressive prevention approach because his risk is higher. He also had a very positive family history. So that made sense to me. But I'm not adding other medicines to lower the LPA, and we don't keep measuring the LPA because I don't know what to do with the number.
Thank you. One more quick question. You may have kind of gone around it. This is another group of patients we are seeing more and more are people who are getting calcium score early in their lives. Last week, I think I saw 2 in their 40s, and one of them went home and calculated his ASVCD score, and it's very low, but his calcium score is 80 or 90. I recommended statins. Did I do the right thing?
Well, so let's talk about what risk scoring is. That's probabilistic, right?
Yeah.
What is a calcium score? It's deterministic. It determines whether you've got coronary atherosclerosis. Here's the problem. We don't have a lot of data for people with 1% risk who are randomized to statin therapy or not statin therapy. Where's that study? I don't have it. So you have to use clinical judgment. There's a great saying by the father of evidence-based medicine, some people call him the father of evidence-based medicine, David Sackett, who said in the 1990s, if you just go by pure external evidence, you deprive people of some common sense reasoning that could make sense. But if you just use clinical judgment, You deprive them of the latest scientific techniques. The best medicine, he felt, was a combination of clinical expertise and using the latest and best external evidence. The best external evidence says that calcium scores are very helpful for reclassifying your risk. And that may be a person you want to follow very carefully. Whether you give them a statin or not, there's a lot of variables present, so I can't give you an absolute. If they had a lot of other enhancing factors, like a family history, I would tend to favor that maybe I'm going to go beyond the guidelines and treat that. But I don't want to kid myself to thinking I know that that's the best thing. There's a benefit risk there because their risk is low. But if they've got a lot of calcium, I can't walk away from that, and I've got to put that in the context of a clinical decision. Sorry if I can't give you just yes or no.
That's better than I thought.
Yeah. Yeah, yes.
Can you use that?
So Neil, excellent
Before
presentation.
you say something,
Yes.
Param, I know you have not been introduced. I know Neil introduced you. But if I could embarrass you and stand and look back, Dr. Nasser was just hired, and actually he will be starting as head of our cardiovascular prevention and wellness program, and will be the co-director of Center of Outcomes Research, coming from Yale, and certainly with a lot of expertise in this wonderful field, and I think it's great to have you. So we'll welcome you at the same time.
Thank you, Bill. Neil, fantastic presentation as always. And then again, I've learned the most from the 2000 guidelines, especially on the shared decision-making. And that was a pivot for us in redefining the role of a calcium as a shared decision-making tool. So just from your conversation, I think so if you look at the guidelines, which are pretty clear, if you are greater than 75th percentile for your age and gender, so somebody in the young age 40s would, with a score of 80 would definitely meet that criteria. I agree there are no yet studies, but we can look back to a very small evidence from the St. Francis Heart Study, randomized 1,000 patients with calcium score greater than 75th percentile, 500 individuals in each arm with atorvastatin of 20 and placebo, and in 4 years they saw a 3% absolute risk reduction. The p-value was 0.08. If they had 500 more patients in that study, it would have been statistically significant. So again, we have to put the things into the context. The question I have for you, Neil, is that now based on the guidelines, of course, we want to start having this conversation based on calculate and then personalize and then reclassify. One of the challenge operationally, which I feel, is that now based on that guidelines, we should be having that conversation with nearly half of the adult population age 45 and above, who would meet that criteria 5% and above, or it should be 33%. So how the classification is easy, but how do we expect the primary care to go into the details of the personalization and reclassification? Do you think there are better options that we can summarize for them, like one thing that could help them the most, number one, or do we think most of these individuals should come up to have some more specialist visits with a preventive cardiologist?
Well, that's a tough one. We think the electronic medical record's very handy. At our institution, I type in .ascvd, and their 10-year risk comes up with all the risk factors that are in the EMR listed. You could then add your own dot phrase, as I have, called enhancing, which will give you the enhancing factors. You can just quickly look and see how they apply to that patient. So right away, you're off and running. We're on the forefront of just learning how valuable calcium scoring is going to be. We need more studies. And the reason I always just hedge my bets on things is because when people get them at very young patients, it's always hard to know just what they would do. But you're right, the St. Francis study, not perfect, was a terrific study. And so, but again, if they had kept measuring calcium in all those people, they would have noticed the calcium scores were going up. So they needed not to measure the calcium score and use it as a marker. And so I think that was an important point too. So I think you're going to be important, Khurram, and leading those studies to tell us how to better use the calcium score.
Any other questions?
Anybody have a question on triglycerides?
And triglycerides.
Yeah.
Thank you so much for a very elegant presentation. We know, I like your case where you showed that lifestyle changes can have a dramatic impact on LDL, although most of the studies showed that even with the best lifestyle changes, low-fat diet, exercise, you only get 5% reduction in your LDL. I have people who come in from PCP offices, they're in their 40s, they're in their 50s, their LDL is like in the 140s, and everyone tells them, no, I'm just using lifestyle, and I'm gonna get the risk reduction. So in these people, how do you judge or how do you make a case whether statin would be more indicated because the relative risk reduction in LDL is not gonna be high based on lifestyle changes alone, especially for LDL?
Well, so I tell everybody that there's a two-fisted approach to lifestyle. There's a big debate. How many are pro-carbohydrate? How many are pro-fat? My personal feeling is I gotta know about both. Bad carbohydrate, sugar-sweetened foods and drinks, soft drinks with sugar clearly increase your risks. And some people are very sensitive to white flour starches. But good carbohydrates, I'm going to get rid of whole grains, I'm going to get rid of fruits and vegetables, I need them as part of a heart-healthy diet. Fats, bad fats, deep-fried foods, coconut oil, for example, we found really raises LDL in certain people tremendously. Butter, egg yolks, 30% of people are sensitive to egg yolks. I have a patient whose cholesterol went up 100 points on 2 eggs a day, 2 egg yolks a day. So, but the person who comes in after him may not budge at all. So you've got to be selective. But good fats like extra virgin olive oil, canola oil, we've got data on those two fats. So a balanced diet, a Mediterranean-style diet, I think makes a lot of sense, but you're right, it may not be enough. And that's why we have to use this risk equation, because starting statins on everybody is excessive. There are side effects to any drug. And so what you want to do is try to tease it out. But if your LDL is 130, 140, you do have higher risk. Now remember, the big advantage of the 213 guidelines that talked about risk is there were white women 50 to 65 who had a very low 10-year risk, but LDLs of 130, 140. They get statins, they get side effects. Right away, we're wondering, what are we doing? Her African-American counterpart, that was the beauty of the pooled cohort equations. We had a separate equation for African-Americans. She had a much higher 10-year risk with the same risk factors. She needed to be on the statin. And so I think using these pooled cohort equations could be an advantage, remembering that they overpredict in some people. That's the people who show up for clinical trials. They're trying to do everything perfect. Some of the people in some of these large studies who they look at, and that's probably true. But likewise, if you have low SES or you've got inflammatory diseases, the pooled cohort equations may be under-predicting. And that's where the risk-enhancing factors, I think, are so important. So I think an essential conversation is be smart about carbs, be smart about fats, and most important, think about your risk, because at the end of the day, that's really what we're managing.
Wonderful. With that, Neil, thank you so much for sharing your thoughts with us. I invite you to join us in a few minutes for a live discussion with Dr. Stone, and see you next week.